Again, thank you for sharing, dear Professor Erik Stalberg, one of the eminent in clinical neurophysiology community. So it's really my privilege and honor to be with us for repeated times. Yeah. So this series, it will be one of the best and one of the important issues that many of us do not know a lot about macro EMG. And what about the clinical utilities? What about how to perform it, especially when doing it with concentric needle, which is really interesting, and how to interpret the findings of the macro EMG. I think I listened to a talk for Professor Jabri at Los Angeles, but we are now with the eminent, the king of the EMG, dear Professor Erik. So screen with you. We can start now, dear Prof. Okay.
Thank you very much. Thank you for the invitation. Today we are talking about macro EMG, and that is, I don't know who came up with the idea, because this is a method that is not used in many places in the world. We have used it quite a lot and we find it useful, and maybe it's good for you to know that you can do this with the electrodes and cables and everything that you already have in your laboratory. You don't need to buy a new thing. And probably your EMG machine can also be set up for that. So it's no extra cost. Earlier we did it with a special macro EMG electrode that you will see, but now they do not produce them any longer because they are very expensive and people were not so interested. And now we have to do it with the concentric electrode, and that is not the best method, but we hope in the future that we can improve it and get another electrode. But so far it is still working with the concentric electrode. So you can use this technique both for research and for follow-up of your chronic patients, post-polio, ALS, and so on. And that can be very useful. And the whole procedure takes about 20 minutes and you get a lot of information. So this will now be a video for 30 minutes, and then I have a short a live demonstration and a few concluding remarks, and then we have some minutes for questions and answers. So we start with the lecture, please.
Okay.
We are going to I don't hear. But talk about the technique called macro EMG. This was developed in the 80s and has been used in different neuromuscular disorders, but not so much in routine. Why is macro EMG indicated at all? Well, the biological background is that muscle pathology is unevenly or patchy distributed within the muscle and even within a motor unit. And our conventional EMG techniques, concentric needle EMG and monopolar needle EMG, they record just from a small part of the motor unit and may see different types of changes depending on where the electrode happens to be. Another thing is that these techniques do not give any information about the total size of the motor unit, which is sometimes good to know. Here are some examples of the patchy pathology. First, in myopathy, where we can see different types of changes fiber diameter variation. We can have very large fibers and very small fibers. And if the electrode now happens to be in this area, it gets another picture than if we are in this area. We have interstitial tissue, more or less. We have central nuclei, here, here, here. And we have fiber splitting. Here is a split, here is probably a split. And these changes are unevenly distributed within the motor unit. The typical thing for concentric needle EMG, a general picture is that we have low amplitudes because of loss of fibers. We have polyphasic changes because fiber diameter variation. Some fibers conduct faster than others. We have early recruitment because of, I think, weakness of the muscle fibers, and we still have normal number of axons. And sometimes we see high and short signals, and they should not be mixed up with neurogenic changes, because neurogenic are high and long duration. These are short duration, and that can be detected with macro EMG. Here is such an example from a myopathy where we have some small, maybe polyphasic motor units, but also these exceptionally high amplitudes with very short duration. And earlier, this has been interpreted as neurogenic, but it is not. This is typical myopathic. And then we have the other situation, namely during reinnervation, we have the following situation. Here are two motor unit territories, one here, one here, and the fibers are partially mixed with each other in this area. Now, if this motor unit disappears because of entrapment or polyneuropathy or something, we will have these fibers denervated. But here we also have denervated white fibers, but they will be reinnervated by the surviving motor unit. So in this area, it will be a higher fiber density. Here we have some increased fiber density, and also here. And in this part, we will have a normal distribution of muscle fibers. So a motor unit potential that we see in reinnervation due to collateral sprouting is always, first of all, the mother, the normal motor unit that has adopted more fibers from the denervated surrounding motor units. The early sign of reinnervation due to collateral sprouting is never small motor units. It's always the normal plus fibers. If we have another type of nerve lesion, for example, a total cut, then the individual axons, in the best of situation, grow out and find the muscle. And in the beginning, it contacts only a few muscle fibers, and then it grows to very dense motor units. So here, the first sign are the very small motor units, then growing up to large motor units. It's very different. And this is much more common, the collateral sprouting in our EMG laboratories. Here you see such a situation where we, during electric stimulation, has made single fiber EMG, and you see that the jitter in some muscle fibers are completely normal, and that is the normal part of the motor unit. And here are other fibers in the same motor unit that shows a very large jitter. So we have normal parts of the unit and abnormal reinnervated parts of the motor unit. And here's a schematic drawing of reinnervation. We have the mother motor unit here, and no reinnervation has taken place here. But when we have early reinnervation, we often get late components because of the slow conduction in these muscle fibers. They have been atrophic while waiting for reinnervation. After some time, they grow in size and have a shorter latency and come closer to the main motor unit. And new fibers are coming in, and they slowly go closer and closer to the main motor unit, fuse into that, and gives the pattern of increased size with some jittering components. So that was the background why we can have advantage of recording with a large recording electrode. Here are different types of electrodes that are available. Single fiber electrode here with a very small uptake area. You see this is the size of an average motor unit, 5 to 10 millimeters, and here's very small uptake area. Also the concentric or the monopolar electrode, they only take a small portion of the motor unit. And here is this so-called macro EMG, which is recording from the cannula of a concentric or single fiber electrode. That is a very big piece of metal that is already in the muscle when we do EMG. And that the uptake area of this is certainly as long as the electrode. And here is the surface electrode that can more diffusely see a large number of motor units under the skin, about 1 or 2 centimeters under the skin. Here's again the repetition of this. We have a motor unit here during reinnervation where some corners can be heavily reinnervated. Other areas can even show fiber atrophy, smallness of fibers or loss of fibers. The recording territory in the macro EMG looks like this. Here the red is a symbol of the muscle and the black is symbol of one motor unit. And this is in the picture a little too big because motor units are much smaller in relation to the muscle. Here is the modified single fiber electrode where we have the cannula inserted through the motor unit, and this we have made to 15 millimeters, and the motor unit is usually much smaller than that. Here we have a single fiber recording as well. I will tell you why. And here is another technique where we use the concentric needle electrode cannula. That has been called CON-MAC. Dr. Jabre wrote about this, where we record from the cannula, and we also have the conventional EMG here. The principle for macro EMG is that it is a non-selective recording that gives us a possibility to see the entire motor unit. The recording is made from the electrode shaft, either from a modified single fiber electrode or from a concentric needle electrode. And then we need a separate electrode that has better selectivity to mark the motor unit that we are interested in. That means trigger from some of the fibers. And here is that type of philosophy. if we just record from the cannula of some of these electrodes, then we see a signal where we do not detect the individual motor units because they are all a summation pattern. If we then, in addition, record simultaneously a more selective part of the motor unit, for example, here the concentric needle electrode motor unit potential that is repeated, then we can imagine that this is the same motor unit as this one, and here is repeated again, but it is superimposed by others, so you cannot see that they are the same. But if we now trigger an averager with this signal and send the cannula signal to the averager, then we will be able to extract the contribution from one motor unit, and it will look like this. So this one will be added to this one and to some 100 discharges, and we will finally get a very clean representation from one motor unit, and the others will disappear because they change in shape for each discharge. And this is the macro EMG signal, and we measure the peak-to-peak amplitude and also the area under the signal. Technically, we do in the following way. We have the recording cannula here, and when I say modify is because we have insulated part of the cannula and have only 15 millimeters bare. This is in order to get the constant size of the recording electrode. And we record on one channel between the cannula and the single fiber electrode, and then on the other channel between the cannula here and the separate surface electrode. So it's a two-channel recording. We can do the same thing with the concentric needle electrode, where we have, if we have the electrode modified, then we can get a constant size of it, but usually we have to work with a full size concentric needle electrode, and that is a bad thing because we have different length of the recording, and that will influence the macro EMG signal a little, but at least it gives a rough estimation. And the same electrical coupling between the shaft and the central lead, that is the ordinary concentric electrode recording, and between the cannula and a separate surface electrode. Then we get the macro signal here and the concentric signal here. And it's actually very easy. If you have an EMG equipment with two-channel input, you can simply do the following. In one of the inputs, you put the concentric needle electrode. And as you know, you often have small extra connectors. If you look at your equipment, you can see that there are small extra connectors. And one is the reference and one is the active part. What you have here is an ordinary concentric recording. But if you take a cable and connect this reference, which is the cannula, and make that to the active here, and use a surface electrode as reference, then you have obtained a macro recording on channel 2. So it only takes a surface lead and it takes an extra little cable. The recording is done in the same way as we do the, for example, multi-MUP recording with a slight voluntary contraction. We trigger on the EMG MUP signal, and then on another channel we get the macro EMG signal. One problem here is that the so-called size principle will be in action, namely with slight voluntary contraction we get the smallest motor units. Here is a distribution of the size of the motor units, and this is the recruitment threshold. And the macro EMG size will be higher and higher for later recruited motor units. Late recruited motor units are larger than early recruited motor units. But normally we use a third of maximal strength. Nearly all recordings are made in the lower portion here. So the reference material that we have developed is also valid for the low threshold motor units. We know from different studies that the macro EMG signal amplitude is positively correlated to number and size of muscle fibers in the motor unit. So it is really a recording of the size of the motor unit. We know that macro EMG amplitude is more sensitive than the concentric amplitude to estimate the number of muscle fibers, for the reason that I said, that it is a more generalized recording. And the other thing is that the macro EMG records from the low threshold motor units. And the technical aspects, the electrode, the very best is a modified single fiber electrode, but they are expensive, and we do not nowadays recommend this. The second best is a modified concentric electrode that is partially insulated, but they are at the moment not commercially available. And then in practical terms, we use a regular concentric needle electrode. We use a 2-channel EMG equipment. We have the filter setting should be open filters, and we must do a simple external rewiring as I showed. Slight voluntary contraction. We trigger on the motor unit potential. We average 100 times or 200 times. You know, with the firing rate of 10 per second, it only takes 10 seconds to record a macro EMG. And we measure the peak-to-peak amplitude. All these things are technically taken care of within the machine, so you don't need to do anything extra here. We had developed some reference material with the modified single fiber electrode. The concentric is about the same normal values. And here we have, with age, the motor units become larger and larger, so we must relate the reference values to age. And here is for biceps and vastus lateralis, for example, where the median value is 70 up to 120, and in the vastus lateralis it is from 110 up to 210 with different age decades. But we are also interested in individual motor units to look at outliers. So the median value at age group of 20 to 29 should be between 65 and 100. That is the median. That means the average of all the recordings. But individual macro EMG can be up to 350 microvolt. So we have an upper normal limit for that and a lower limit. And now I will show some examples of macro EMG signals in myopathy and neurogenic conditions. This is what we see in normal subjects. Usually we record 20 motor units. Here maybe I should have averaged a little more to get a more flat baseline, but peak to peak is okay. Peak to peak here, peak to peak, and so on. This is the normal variation from small to large motor units in a tibial anterior muscle. Here are the small macro EMG signals in polymyositis. And you know that sometimes in polymyositis you get short, high amplitude signals and you say, oh, is it a neuropathy also? And you misinterpret the recording. If you then do the macro EMG, these single high amplitudes come from just one fiber and they do not contribute to the macro signal. And here is in a neurogenic condition, you see the much larger signals. This is in a patient with a post-polio, not polio, but sequelae after polio. We have looked at the polio patients in special projects over many years and seen some interesting things. This is the size of the macro EMG, and we have recalculated that to comparison to normal values. So here is a motor unit that is about double the normal size. Here is a motor unit that is 4 times the normal size. So the size is here, and here's the strength in the knee extensors. And you see that these patients, each symbol is one patient. This patient has double the size of the motor units. Here 4 times the normal motor unit. And you know, if the average is increased by 4 times, then you may have lost so many motor units that you have only 1/4, 25% left, and still you have a normal strength. It's fantastic, effective reinnervation, and the highest we get is some up to 10 times. But usually when the motor units become bigger and bigger, then the strength will fall down and become smaller and smaller. It's not a perfect correlation, but it is distinctly so. And motor units can become up to 20 times the normal size. We have followed patients over a few years. We have a 4-year follow-up. And you see as an example that this patient, his motor unit was 10 times the normal size, and next time after 4 years it's 15 times normal. Here's another 11 times, and now it's more than 20 times. This one goes from something like 4 times and it goes up to 8 times. You see they increase with time, these motor units, also in patients that had polio 30 years ago. And we say something is going on continuously. And I will tell you about that later. And here you see the very large motor units that we saw the first time. Here is 60 times the normal. Now, next time we see the patient, it is only 45 times the normal. So now when they are very big, they become smaller and smaller again. And here is what we think of in patient that had a polio. First of all, here's the spinal cord with different motor neurons here. And this is what we see locally. These are two motor units that are overlapping, coming from the blue and the yellow neuron here. This is a normal mixed situation. In polio, we first of all have loss of activity in motor neurons with degeneration. Not all motor units degenerate, but a few of them. And the blue one that we saw before have now become black here. They are denervated, but the yellow has survived. This is healthy. After 3 months, the yellow one that is healthy shows fiber hypertrophy. This is what happens normally, that patients with post-polio often have very large muscle fibers in the biopsy because of the survivors have to work much harder. They are trained automatically. But the others, small, but you see fewer because now the yellow has been they are taking over these denervated muscle fibers. And what we see here is that the yellow survivor has taken over a lot of the muscle fibers that are denervated around them. And this will become 10 times, 20 times the normal size. And if they are so many fibers, that neuron has a very hard stress, metabolic stress, and have to work really hard. During these 10 years, we have a continuous loss of motor neurons, which is the physiological aging. In all of us, we lose neurons, and we have a capacity for reinnervation. But the polio patient, they have only a few motor units to start with. And when they start to lose even more neurons because of normal process, their neurons really have to work hard and can finally not sustain all these muscle fibers, and they get something called fractionation, that the motor units have to give up because of overuse. And then we have the post-polio syndrome because of the failing reinnervation that should cope with the physiologic loss of motor neurons. This is how we see this situation in post-polio. And therefore, these patients should not exercise more, because even normal walking is a great exercise. But we say that they should save their neurons, at least in the patient that have a severe loss of neurons. And we measure that with macro EMG to see if they have lost many motor neurons or if they have lost fewer. This is one technique. Other techniques can be motor unit number estimation, but this is similar, but with needle EMG. Here's a comparison with different techniques when it comes to motor units in the normal muscle and in reinnervated and the myopathic. In the normal, we have small motor units
moderately small motor units and large motor units. That is the physiologic range. And we compare concentric and single fiber and macro EMG. Concentric needle EMG gives the same amplitude both for small and large normal motor units, because we only record from a portion of these motor units, so we cannot tell anything about the size. But in reinnervation, the amplitude is increased, and in myopathy, the size is less. Single fiber EMG measures the concentration of muscle fibers, and it is the same with small and large normal motor units, but it is increased in reinnervation, and it's also increased in myopathy because of fiber splitting and so on. And here is now the macro EMG, where the normal small motor units have small macro, moderate size have normal size, and the large normal motor units have large macro EMG. Very large in reinnervation and normal or smallish in myopathy. And the indications for macro is that we can differentiate neurogenic and myopathic situations. We can follow changes in the motor unit size, for example, in ALS and in post-polio, as I showed. And we can also study the motor unit size as a parameter in certain conditions. Now we are going to do some live recordings, but first of all, some introductory slides about practical details. I will show how we make the coupling of the cables from two different EMG equipment. What we need is a concentric needle electrode, or even better, a real macro electrode, which is a modified single fiber electrode. We need a jumper, we need a surface electrode and a ground electrode. And this is the steps. We first insert the cable for the concentric needle electrode in channel 1 input. And then we connect the parallel output here, the reference from the cannula, and the cannula is going in to the active part in this amplifier. And the next step is to connect the surface electrode on some remote place. And now we have an active signal here and the reference. And now we have created a macro channel here and a concentric EMG for triggering here. And finally, we apply the ground electrode, and we are ready for recording. Here is another equipment where we do the same thing. And the first thing is to insert the routine electrode, for example, concentric. And then we connect the reference from the so-called reference part, which is here denoted as a red plus. That is the reference. And we put that into the active input here. This happens to be a white minus. And then we also connect the surface electrode, and finally the ground electrode. Here is the practical way that we insert the needle relatively perpendicularly to the skin, and not only 1 or 2 millimeters, but we really want to have a good part of the cannula inside the muscle, so at least 15 millimeters. We have the reference for macro over a silent area, antagonistic area, or in this case over patella when we are recording from the tibialis anterior muscle. And here is the ground electrode. And here you see it in another angle. So we start from the beginning. I insert the needle and see the motor unit potentials on channel 1. Here are the signals with a sweep speed of 5 milliseconds, which I can change, for example, to 2 milliseconds. We see motor unit potentials. I trigger on the highest, and then we see the contribution here, that the average of all the recorded cannula signals from this motor unit is seen down here with another sweep speed. Now we have 100 or 110 discharges. I think it's fine. I save that one, and we are ready for the next. I move the needle again. We start to average. And now in the beginning, it's very irregular baseline, but and if we go on for a little while, now we have 64, now we have 70, now we have 80, 100, and now I think the baseline is very nice. I stop averaging, I save the signals here. And then I'm ready to take another signal, and we get this macro EMG signal down here. We have enough. We can store and start to record again. This is another motor unit potential, more irregular, a small one here, and that has another shape here, has another amplitude. It's a slight tremor in this recording. I stop. I restarted the averaging. I reset and started the averaging. And you see this one looks irregular because it's sometimes summated with other motor unit potentials. A signal that is very big. These big signals we did not need to average very much at all. Now we have this. I shall see if I can finally find a very small signal. Here is another motor unit. And you see the macro EMG here. And we store that. And now we have obtained a number of motor unit potentials, and they are plotted here, the amplitude versus area. And usually they are correlated like a linear correlation. If we have had large amplitude, also large areas and so on. But we report the amplitude. In this case, it was 800 microvolt, a slight neurogenic picture because this has been a muscle with an L4, L5 radiculopathy earlier. At the end of the study, we are able to look at the individual macro map potentials, usually 30 of them, and we then have possibilities to remove bad quality MUPs or duplicates. The system measures amplitude and area. We do not bother about duration. That is the end of today's discussion.
I think there is an amazing talk as usual, dear Professor Erik. It's very summarized, very simple. You have ability to summarize and simplify any information, big information. Thank you so much, dear Professor Erik. So I think we have questions. Yeah, the webinar it will be recorded and I will share it on the Facebook group and YouTube channel. So anyone has any questions, please put it now. Okay, please. Okay. So I have some questions, dear Professor Erik. You hear me?
Yes.
Good. What about the macro EMG in pediatrics? Can we use it stimulated as single fiber, or it must be volitional?
No, we cannot use it for single fiber because when we stimulate, we nearly always stimulate more than one motor unit. So we get the summation from many motor units. So it can only be made with voluntary activation.
Thank you. Okay. My second question is, in such case, let me clear as ALS. When we can use single fiber EMG and when we can use macro EMG, clinical.
Yes. Single fiber EMG can see the small details when fibers are concentrated due to collateral sprouting. But the macro EMG will tell us the total size of the motor unit. And if we want to follow a patient every 3 months, for example, then macro EMG is much better, much easier to get the quantitation because you see the whole motor unit. In the single fiber, fiber density depends very much on the position of the electrode. So single fiber is used for diagnosis, macro EMG for follow-up.
That's great. Can I ask you a question just far away from this talk today? I think I have a patient at previous week, last week, has step injury for the median nerve.
Yeah.
And found when I did neurography, there is no CMAP above and below the median nerve at the wrist.
Mm-hmm.
I say by neuromuscular sonography, there is a complete cut of the median nerve. But when the surgeon did the repair, we found this is neurotemesis and did the repair. But the interesting for me, there is no any atrophy for the thinner muscles. Atrophy. How can I interpret this?
And then it's anomalous innervation. It may be coming from the ulnar nerve or Richelieu anastomosis. So it must come from another nerve then.
Yeah,
very likely from ulnar. So stimulate the ulnar and record from APB and you will get the answer.
There is a question, is EMG result considered as a valid indicator for muscle strength? There is a question, yeah? You and an A question?
Yes. The answer is yes. If you have a large macro signal, it is very likely that it is a strong muscle also. So they are related.
Related between the amplitude and the strength?
Yeah.
Okay.
Yes, to make it.
Yeah. There is another question. Do you agree that the only indication for macro EMG is everyday practice, apart from follow-up, is to differentiate between myopathy and neuropathy, motor unit potentials. And if that is known by concentric, then there is no need to do macro EMG.
Yes, I agree. I think that's a good, you don't need to do macro EMG in all patients naturally. You do it when you have a question. And sometimes, for example, in polymyositis, when you see this short high amplitude and then you say, oh, a neuropathy, then you should do a macro EMG and you will see that that motor unit with one fiber that gives high amplitude is still small. So that helps very much to understand that this high amplitude is really from one fiber. This is myopathy.
Very good. Any questions? Please, any questions? Please put it.
I have two comments. One is that the participants are going to get handouts from you, I think.
Yeah.
You have got the handouts.
Yeah.
So because they did not hear so well in the beginning here.
Okay. Okay. I will share the handout from Professor Erik in the Facebook group. Any questions?
I have one more comment only, and that is the display of the video was not absolute perfect. We had we only get very few of the signals. Normally we see every discharge on the screen that we heard in the background. So we had a little technical problem, but I think maybe we can understand anyhow. Yeah.
Okay. At the end of this episode, thank you a lot again, Professor Erik Stalberg, one of the eminent clinical neurophysiology professor at Uppsala University. We are learning a lot from your knowledge, your big informations. Thank you again. Hope to share us soon in another episodes, and goodbye. Okay.
Thank you very much. Goodbye.